Interventional radiology or radiography or angiography. The terms are kind of used interchangeably, but they do have slightly different meanings. So, interventional radiology or radiography is the specialty. So, that's kind of the modality that it is. Angiography is the process of taking images of blood vessels. So, it's similar to if you think about like in fluoroscopy. Fluoroscopy is the modality, and the upper GI is one of the procedures. So interventional radiography is the specialty, and angiography is that process of taking the images of the blood vessels. But again, they're used interchangeably throughout the text, throughout this lesson, and a lot of times interventional radiography is also just referred to as IR. So we just kind of use the initials instead because it's a little bit easier. So this is a picture of an interventional radiologist and the technologist in the room with the patient on the table. They've got the x-ray machine here and the monitors behind them so they can visualize what's going on during the procedure. So as you can tell by this, the monitors are very big, they're high quality, so that the doctor can see very small details while he's doing the procedure. And I'll break down how they do it and what each person's role is and things like that as we get a little bit deeper in. So angiography is just simply a minimally invasive medical test that can help doctors diagnose and treat different medical conditions. So angiography uses either x-ray, especially for the therapeutic work, or it can use CT and MR. Remember when we talked about, especially in CT and MRI, we talked about CTAs, computed tomography angiography, or MRAs, magnetic resonance angiography. Remember we talked about how MRA does not need to use radiation or the strong contrast that we use. But it's not going to always work for the same things. So, like I said, angiography can either use X-ray, CTA, or MRA along with a contrast material to help produce images of the major blood vessels throughout our body. So being minimally invasive is great. It gives doctors a second option without having to go in and perform surgery. So why do we perform angiography? Well, kind of like I just said, so we don't have to have surgery. But X-ray angiography is performed to image or view and then possibly diagnose diseases of the different blood vessels of our body, including the brain and the heart. So in the beginning, angiography was simply just used to diagnose pathology of the vessels, like a blockage, okay? So they were just using it to diagnose. But more recently, I mean, not super recently, but within the past decades, radiologists and cardiologists and vascular surgeons started using X-ray angiography procedures to guide minimally invasive surgeries of the blood vessels and arteries of the heart. This became huge. I mean, instead of having that patient have to undergo a major surgery, we could do something very minimally invasive and either diagnose or treat the patient without the cost, the expense, the danger of the surgery. So diagnostic vascular imaging is often using CT or MR, sometimes even ultrasound. And X-ray angiography is also used for therapy as well. So X-ray angiography has a vital role in the detection, diagnosis, and treatment of heart disease, heart attacks, acute strokes, and vascular disease, which can lead to strokes. So some statistics that convey why angiography is vital. So more than 2 out of every 5 Americans die from some form of cardiovascular disease. Heart conditions that could include, diseased vessels, structural problems, and even blood clots. So coronary artery disease is shown to be the leading cause of death among both men and women in the United States and Europe. Coronary artery disease is just a disease or damage that's in the major heart vessels. So this is why angiography is so important. It's helping to diagnose and treat these issues, which is helping patients to live longer. So with that, the deaths from coronary artery disease and other heart diseases continue to go down or decline. And that's due to our improved treatment options and advances in drug therapies that we have. One of the most impressive things to me about angiography is that it can eliminate the need for invasive surgery. So we talk about studies that are non-invasive, minimally invasive, and invasive. So something that would be non-invasive would be MRA or CTA. And that's great for just diagnosing things. But you can't do any treatment during those procedures. So for a minimally invasive study like angiography, you can diagnose and treat or use therapeutic options very minimally invasively by just making a small cut in either the wrist or the groin. And it eliminates that need for invasive surgery, which could possibly mean open heart surgery, where they actually have to crack the chest open. So that's a huge reason why it's so important. Angiography is still performed in a sterile setting, and a lot of times it's actually performed in operating rooms or dedicated suites. So it is done under a sterile setting, which means free of all microorganisms. So a lot of times it's just easier to do them in the OR. Depending on the hospital and what the setup is, a lot of interventional radiology suites have dedicated units that are very large. The x-ray machines are very large, so they usually have a room set up that's dedicated just for them. Or, there's other procedures that they'll allow to be done in there, but it just depends on the facility or site that you're at. But with angiography, to see inside the bodies, doctors can repair blood vessels without a scalpel or without fully invasive surgeries. So, pathology of the blood vessels, like plaque buildup in the arms and legs, neck, brain, and heart, they can be treated using different interventional angiography procedures, such as coronary angioplasty. Coronary angioplasty is used to kind of widen the narrowed coronary arteries. So, coronary arteries, if you don't know what they are, they're the main blood vessels that are supplying blood to the heart. So, how does interventional radiology work, or angiography? Well, what it is it's actually a subspecialty of radiology that uses imaging equipment to guide the doctor in carrying out a diagnostic or a therapeutic procedure on a patient. So, angiography actually uses the same principles as x-ray or fluoroscopy. So, it uses radiation, which is harmful, right? Anytime we use radiation, it can be harmful to the patients. The fluoroscopy that's used during angio, sometimes I use angio short for angiography too. The fluoroscopy used during angio allows the doctor to watch live as they advance the guide wire through the arteries, or to watch the contrast flow to see if there's any blockage or an aneurysm or something like that. So they're using that live imaging just like fluoroscopy to visualize their work as they go. In most of the IR suites, they have a dedicated CR machine. It doesn't look exactly like a standard CR machine, but it's very similar. So it uses fluoroscopy, and some are even capable of CT scans as well. There's a special table with different controls on it that move the patient on the table and also move the equipment around the patient. Angiography also uses ultrasound, mainly to help them in the beginning to find the arteries and veins for the initial incision sites and where they're going to put the catheter. And then it also uses, like I said, CT and MR technology as well. So how the procedure is formed, well, what they do is they get the patient in there, lay him on the table, and then the doctor makes a small incision in the skin, and a catheter, or a catheter is also like a thin plastic tube. It's about the size of a piece of spaghetti. It's inserted into the artery. Most times they either use the artery in the wrist or in the groin to kind of make that incision and start. It depends on what they're looking at and what they're trying to visualize when they decide which site to use. Then what they do is they just slowly advance that catheter under the fluoroscopy guidance to the area that they're trying to look at, or the area of interest. So they'll make that incision, they'll put the catheter in, you center that x-ray right over it, and then as the doctor slowly advances that catheter into the artery, the x-ray machine follows it up all the way till the area of interest. So once the catheter reaches the spot the doctor wants to see, they're going to inject contrast through that catheter. That contrast is going to allow the doctor to see the blood vessels in that area or assess for any abnormalities that would be going on, such as a rupture or aneurysm or clots, things like that. And then the whole time they're doing that, they're capturing images, so they can save images just like a normal x-ray using ionizing radiation during that procedure. So up until this point, the procedure is completely diagnostic. You know, they're going through, they're looking at things, they're checking to see if there's any diagnostic reason to do a procedure. But if the doctor finds an issue, that can then turn into a therapeutic procedure at that point. So everything can kind of be done under one procedure without the patient having to have a diagnostic exam and then come back later for the surgery or a therapeutic procedure. They can decide at that point, yep, we see a blockage, we're going to put a stent in. So at that point, like I said, if the doctor sees something, they can do different things like place a stent, they can clear a blockage, they can stop bleeding or an embolization, they can cut the blood flow to fibroids, and they can also remove blood clots. So there's a lot of different things that they can do at that point when they figure out what is truly going on with the patient. So this is kind of what an angiography or interventional radiology suite looks like. So here's the machine itself. As you can see here, it's ceiling mounted, and this is what I mean when I say a C-arm. See how this looks like a big C? I believe I showed them in either the fluoroscopy section or even in the general radiology section. We use them a lot in the OR for procedures, and we can move them throughout the hospital. But this one is ceiling mounted, so it can't go anywhere. Here's the table. You've got all the controls down here, which the technologist, the radiologic technologist, is going to run. And then in all these cupboards in here, they have all the different types of catheters and equipment that they would need. In interventional radiology, there's usually large monitors and multiple monitors, so the radiologist that's working in there can get a good visualization of the images that they're trying to look at. So, like I said, there will be this X-ray machine or C-arm, just like this one, and sometimes there's two C-arms used simultaneously, and the next picture I have will actually show you what that looks like. The machines, they either use fluoroscopy, and some of them are capable of creating those CT slices. So a lot of times they'll do like small little snippets of CT. Depending on the length of these exams, they can be a larger radiation burden. You know, it's live fluoroscopy, and some of these procedures can last between, you know, an hour to 2 hours, 3 hours, depending on what they're doing. So that could add up to a lot of radiation. We also use an iodine-based contrast to help visualize those vessels. What the procedure is kind of like is the patient will have to undress, they'll have to remove all their clothing, jewelry, put on a gown, and then the patient lies flat on this table. Now, the positions might be different. It's going to depend on what they're trying to visualize. If it's their legs, their head's going to go down at this end, their leg's going to go down here. If we're looking at their heart or their carotid artery or the brain, the blood vessels in the brain, their head's going to go down at this end. We can move the machine more frequently, but we want to center the area of interest closer to the end of the table where the machine is at. So after the patient removes everything, lies down flat on the table, they will start an IV. The IV is used for IV contrast as well. So depending on the exam that they're doing, they'll either inject contrast through the IV or through the catheter. And then a small incision will be made either in the wrist or in the groin. It's, like I said, again, depending on, sometimes it's just the doctor's preference, sometimes it's the area of interest that they're looking at, different things. So during the procedure, the technologist and the doctor will remain at the table side. Usually they both work on the same side, or one works on the other. So they're going to be doing that to operate the angiography system, which is controlled down here, and then to work with the catheters, contrast, and relatable devices. So it just depends on the procedure, the doctor, things like that, but some facilities, they might even have two technologists, one to run the machine and one to assist the doctor that's sterile as well. Typically, the patient's given what we call conscious sedation, so they're relaxed but they're awake. A lot of times we call it an amnesia drug because the patients might not remember everything during that time, but they're going to be awake the whole time. They just won't remember it. Like I said earlier, some procedures can take 2 hours and some can take less than an hour. It's just going to depend on the level of difficulty, what they're trying to look at, what they find when they get in there. This is another one. It's very similar, just a different view. This one has the two machines together. So you've got two different views. And what's nice about this is this one can do the CT slices because you've got two different views. So you don't have to move the machine as much. And again, you've got your monitors over here where you can see everything. This machine is moved on a ceiling track back and forth. So it can move up and down the table, and then here's your controls again for the table to run the C-arm and to move the table. So this is DSA, or digital subtraction angiography. So it's a technique that's used in IR to actually remove or subtract radio-opaque structures like bone or tissue that allows us to clearly visualize the blood vessels. So, I mean, like if you see here in this slide, you're mainly being able to focus on the bone. In this image here, they've completely subtracted the bone and any soft tissue anatomy so that they can just visualize the blood vessels without anything in the way. And there's different levels of the subtraction here and here. You can see where you can still kind of see some of the soft tissue in the outline, but this one is completely subtracted. This here is an image of kind of what the doctor would look like here in the sterile field. This is the catheter that's inserted here, and then he's advancing the guide wire. So he just slowly pushes that down in. Here's the catheter that's kind of coming in till you get right into the artery, and then the guide wire would come right down here, and it would advance through that artery there. Here's just another view of what they do. So you insert the needle. Once the needle is in the vessel, then they'll actually remove the needle to take the needle actually all the way out. So then you just have the catheter in there, and then they can put the guide wire in. This one they say it kind of opposite. They actually put the guide wire in and then pull the needle back out. So then they can just thread that guide wire in through the catheter. Then when the procedure's all done, they'll pull the guide wire all the way out, and then they'll remove the catheter. The pertinence to the medical community is pretty big. So it's a fairly quick, minimally invasive study that allows the patient to not have to undergo surgery. It can be done on an outpatient basis, which makes the procedure a little bit easier, and it makes it cheaper for the patient and the hospitals. But it provides excellent evaluation and treatment for aneurysms, bleeds, clots, fibroids, stenosis, and cancers. So aneurysms are just like small little sacs within the artery. What happens is when there's a weakening in the lining of the artery, that little sac or outpouching happens, and if blood gets in there and pools in there, because the wall is thinner, it can't hold that pressure and they can actually rupture, and then the blood is escaping from the blood vessels. So what we can do in that situation is put in coils, and I'll show you guys a coiling procedure a little bit later that will stop. We do that before it ruptures. What it does is it stops the blood from flowing in there, and it kind of bypasses that aneurysm. It's used to treat bleeds, so they can do catheter embolizations that block the blood flow. They can either inflate a balloon or put a gel or foam in there to actually stop the bleeding. And those are done a lot in emergent situations. Sometimes if a woman has a baby and she's hemorrhaging and they don't know why, they can quick get her into interventional radiology, figure out where she's bleeding from, and stop the bleeding. Same with trauma situations. So depending on where the hospital is located, if it's a trauma center, then there might be an interventional radiology suite where they are on call or staffed throughout the night for trauma situations like that. It also treats and evaluates for blood clots, so they can remove a clot or break one up into smaller pieces. They can place a stent, or they can use a balloon to kind of open up that vein a little bit more. Fibroids, to treat those, they actually go in and they cut off the blood supply for the fibroid, so it actually dies off. For stenosis or narrowing, what they do is they can use balloons to kind of open that area up, or they can break up the plaque, or they can put in stents to kind of help open that narrowing up. And then for cancers, they usually use that to cut the blood supply from a tumor, and they can also heat and destroy cancerous cells in there. So they can use those guide wires to get right up close to those cancerous cells, and then they can heat them up and destroy them. So interventional radiology can do a lot. There's a big pertinence to the medical community, especially, like I said, in trauma situations or things like that. But interventional radiology also provides excellent evaluation of the cardiovascular system, which cardiovascular, the cardio stands for heart, and vascular stands for vessels. And the cool thing about these is, I don't know if you guys have ever heard about coronary bypass surgery, or if you know anybody that's ever had them. My husband's grandfather's had it before. But interventional radiology can possibly replace coronary bypass surgery with coronary angioplasty. So what coronary bypass is, it's an invasive surgery, so they have to be opened up, where they use either a synthetic, which is a man-made blood vessel, or vessels that have been grafted from other parts of the body. And what they're doing is they're creating an alternative passage. So if there's a blockage in one of the coronary arteries, what they'll do is they'll make an alternative passage and bypass that clogged blood vessel. So the new blood vessel will bypass it. So a lot of times I always tell people to kind of compare it to that highway bypass. You know, when you're traveling, you'll take the bypass to go around the big city where all the clogged traffic is. That's the same thing that they're doing with coronary bypass surgery. But with coronary angioplasty, which is done in interventional radiology, that can be done without the intervention or invasive surgery. And they can actually use stents to kind of reopen those clogged vessels. Now, it's not always interchangeably 100%. You know, there may be times where angioplasty is not an option and they need to do coronary bypass, but it is that option for some patients, and it's a much better option than having to go in and have surgery. So the most frequent exams that they do in IR are line placement for PICC lines or portacaths. If you don't know what those are, PICC lines actually give doctors access to the large central veins near the heart. So generally those are used to give medication, but it helps if a patient is sick and they need frequent needle sticks, or if the patient doesn't have very good accessible veins, they'll put a PICC line in. And you'll see it a lot in the NICU for babies. They'll have to have PICC lines put in just because it's too hard to constantly needle stick a baby. So they'll put those in. Sometimes they'll put them in their arms. I've seen them where they put them in their little heads. I always feel so bad for those babies because it just looks so terrible. I'm sure it's, you know, they probably don't even notice it, but and they do it a lot in patients that are really sick too, where their veins aren't good, so it's hard to get access to a vein. Portacaths are a little bit different, similar concept, but they're a small medical appliance that's actually implanted or installed just right beneath the skin. I mean, right under that. You can feel it through the skin. And then a catheter connects the port to a vein. So they can be used to draw blood, give the patient IV fluids, drugs, or blood transfusions. They can stay in place for weeks or months. And the same thing, they're to avoid repeated needle sticks. A lot of times, cancer patients will have portacaths put in. That way, when they need their chemotherapy or they need drugs or anything like that, then they can give them right through that, and they don't have to needle stick them every single time. IVCs, or inferior vena cava filter placements. The inferior vena cava is meant to carry blood from your lower body to your heart and lungs. So if there's blood clots lodging in the lungs or the heart, that can be really deadly. So an IVC filter is placed in your inferior vena cava to prevent that clot from going through your body or traveling in your blood into your lungs. One of the other frequent exams is angioplasty. Oh no, I skipped embolism, sorry. Embolism, which is just preventing blood flow to a certain area. Angioplasty, which would be repairing or unblocking of a blood vessel. And then for aneurysms or stenosis, the aneurysm is the enlargement of the artery caused by that weakening of the artery's wall. And then stenosis is just the narrowing of the blood vessels. So those are some of the most common exams that are used in interventional radiology. So this is this is showing you the renal artery here. So from here to here, it kind of blows it up for you. And there's a lot of fatty plaque in that renal artery. So blood's not flowing very good. So what they've done is they have used that catheter to put a guide wire in. They've got the guide wire all the way into the renal artery. And then what they do is they'll actually put a stent right over that guide wire. And then they're going to follow that all the way down, push the stent a little bit further past the area of the plaque. And then what they're going to do is they're going to inflate a balloon that's inside of that stent. So what that does is the balloon blows up and it pushes that stent up against the walls and kind of smushes that plaque down and opens up that artery. Then it'll lock it in place, and then they can deflate that balloon back out and then pull the catheter back out in the guide wire. And then you've just got that stent in place that's opened up that blood flow again. It's really quite amazing what they can do. So this is a difference in MR angiography or MRA and conventional angiography. So with the MR, it's non-invasive. There's no contrast required. They might use some of the gadolinium, but it's non-ionic. And there's no radiation. So they're able to visualize these blood vessels in great detail. And then you've got conventional angiography, which is invasive. They've got to make a little incision in your wrist or your groin. They do use contrast. They call it nephrotoxic contrast on this one because it can be toxic to the kidneys. And again, they're using ionizing radiation, which can be harmful. So you still get great quality images. And if you're strictly trying to diagnose, then MRA is a great option. But if there is any chance that you might want to do a therapeutic procedure, you would have to reschedule the patient and get them in at a different time. So this is a video that I have on blood clot removal for stroke. So I'll pull that up here just a second. Okay, my fault. This was not a video. I thought this was a link to a video, but it's just a link to the website with an article about this, how they can actually go in and remove the blood clot. But so they can go in with kind of this claw, wrap it around the blood clot, and then remove it to help relieve the damage from the stroke and prevent any further damage. So this is a renal mass. So on the left side here you can see this increased vascular on the renal mass here. Okay, so here's the entire kidney, right? So you've got the outline of the kidney here. But within these arrows, 1, 2, and 3, you can see the difference in the vascular in here, right? There's a lot more, which what it is that's actually the blood flow to the tumor. So this is renal carcinoma. So angiography isn't without limitations. I've said, before that it's really great and everything, but any patient that might have impaired kidney function, especially those patients that are diabetic, they're not good candidates for this procedure. So the contrast that we use, the iodine-based contrast, can actually cause kidney failure, and I did talk to you guys about that in CT and IVPs a little bit. So we don't want to give the contrast to a patient that has kidney disease. And diabetic patients, they actually have a higher risk of long-term death, a second heart attack, or a blood clot formed on the stent compared to patients who are not diabetic. So both patients with impaired kidney function and diabetics are not good candidates for the procedures. If a patient can't lay still, so a patient needs to lay still for up to 6 hours during the procedure and after in recovery, it's really important that they lay flat so that it doesn't induce bleeding. So if the patient's unable to do that, then they wouldn't be a good candidate. Patients who have had a previous contrast allergy shouldn't have this study. If it's absolutely essential, what they can do to decrease the risk of the contrast allergy is to give the patient either like a steroid medication ahead of time, kind of pre-treat them, or possibly use a contrast without iodine. There are times that we do use like gadolinium, which is the MRI contrast, because it's non-ionic. We can use it in patients who have iodine allergies and it won't cause a reaction. But it doesn't show up as well. It just doesn't give as good quality images, so they don't tend to use it if they don't have to. And then also any kind of catheter angiography procedure should be done very cautiously or not at all on patients that have a tendency to bleed, because obviously if they tend to bleed, we don't want to go in there with the catheter and then cause more bleeding. Benefits. There are quite a few benefits for interventional radiology. So angiography can eliminate the need for surgery. That's huge, right? If you have the choice between a minimally invasive study and surgery, which would you choose? So if by chance that the surgery is still necessary, it actually makes the surgery that they're going to be able to do more accurate because they know exactly what's going on because they have the imaging to back it up. Catheter angiography presents a very detailed, clear, and accurate picture of the blood vessels. So this is really helpful when a surgical procedure or some percutaneous intervention is being considered. By selecting the arteries through which the catheter passes, it's possible to assess vessels in very specific body sites. So what they can do is, if they need to get into a very tight area, they can actually use the catheter and then pass a smaller catheter through the larger one into the different branch arteries. So it makes it able to move a little bit more. Unlike CT or MRI, the use of catheters makes it possible to combine the diagnostic and the treatment in a single procedure. So an example is like finding an area of a severe arterial narrowing caused by angio, and then they'll do the angioplasty and a patient placement of stent. So those things wouldn't be possible if we were doing CT or MRI because those are strictly just for diagnostic. The degree of detail displayed by catheter angiography may not be available with any other non-invasive procedures. And then one of the other things is no radiation remains in the patient's body after the exam. It is still a larger dose because it's the fluoroscopy, which is a continuous live, and they're using quite a bit of radiation to follow that guide wire and to, put the contrast in and throughout the procedure. But like I said before, X-ray usually has no side effects. I mean, there is always the risk or increased risk of cancer and cataracts down the road from a lifetime dose of cancer. But there are truly a lot of benefits to angiography. I mean, but the one above all is just simply eliminating the need for surgery. Risks, well, like I said before, even though I said there's no risk, we list it as a risk because anytime we're giving radiation to a patient, there's a slight risk of cancer developing later. There's a risk of an allergy to contrast. If you have a history of an allergy, then the radiologist may advise you to take a special medication for 24 hours before the exam to kind of premeditate to kind of stop that allergic reaction from happening. If there's a large amount of contrast material that leaks out into the skin where the IV is placed, then skin damage can result. Another risk would be, if there's a possibility of pregnancy, they're going to ask the patient ahead of time. They're going to do pregnancy tests, things like that, to kind of eliminate that. Nursing mothers, they should wait 24 hours after that contrast material before resuming breastfeeding. Again, the risk of severe allergies or allergic reactions up to death could be possible. There is a small risk that blood may form around the clot where the tip of the catheter is. If you have kidney disease or diabetes, your kidneys may be damaged from the contrast. And then very rarely, the catheter can puncture an artery, causing internal bleeding, which obviously is never good, but it's very rare. And there is also the risk that the patient could still need surgery after this interventional radiology procedure, it's usually like a 0.1% risk of still having to have surgery. Preparation for the procedures for angiography are NPO for 8 hours. So, unless it's something emergent, obviously if it's a trauma situation or emergency situation, they're not going to worry about the patient being NPO. So nothing to eat or drink for 8 hours prior to the procedure. The NPO is going to help eliminate that nausea and vomiting that we talked about when we were giving contrast for CT. But it also keeps the patient prepared just in case they need surgery. The worst possible thing that could happen is if the patient needs to lie flat for 6 hours and they also feel like they need to vomit. So we try to keep them NPO. Bleeding is also a concern during interventional radiology procedures. So if a patient takes any blood thinners throughout their normal life, they need to stop taking them for 5 to 6 days prior to that procedure. Diabetics, if the patient's diabetic, if they're taking glucophage or metformin for treatment, they need to stop taking that for at least a day, at least 24 to 48 hours prior and after the exam, because that interacts with the contrast and it can actually cause kidney failure. So speaking of kidney failure, they'll also want blood work done prior to the scans. So they're going to want to check the kidney function through blood work. So BUN and creatinine, they're going to show the kidney function levels. And then they also draw the PT and PTT, which is a partial thromboplastin time. That evaluates each person's ability to appropriately form blood clots. So everybody should be able to form blood clots or get their blood to stop clotting. But if someone's clotting time was really, really slow, which means they tend to bleed a lot easier and their blood doesn't clot, there's the possibility of not being able to stop that bleeding. So that's why they want to know that. After the procedure, the patient's going to need a pressure bandage wherever that incision site is, so either on the wrist or the groin area, to help stop that bleeding. And then the patient's going to need to lie flat if the incision's in the groin, or if it was in their wrist. They don't want them using that wrist or raising their hand up or bending it or doing anything like that. If the patient was given a sedative, which most of them are, they don't want them to drive for 24 hours. So the patient's always going to have to bring a driver with them, and they don't want them to drive for 24 hours after the procedure. Patients are given a sedative, and the doctor is going to numb the injection site. So those are some of the things that they do to prep the patient. But there are some side effects, just like we talked about before with any contrast. So warm flesh feeling, metallic taste in your mouth, nausea, vomiting, and dizziness. So make sure to convey those again to the patients. Like I said, we use conscious sedation, but that patient is still aware at the time. So even though they might not remember it later, they know what's going on right then and there. So you need to communicate with them and talk to them. Other contrast reactions could be hypertension, tachycardia, heart attack, or possible death. Complications from the procedure can be bleeding, infections. Anytime we break the skin, there's a possibility of infection. The patient could have a reaction to contrast. They could have an allergy. Or, like I said, a lot of times they'll go in there and if something happens or something goes wrong or they find something bigger, that patient still may need to have surgery. Those complications are something that the doctor will discuss with the patient ahead of time. If you've ever had any kind of surgery procedures, they usually downplay it, but they should be telling the patient what the possible risks are. That's a mandatory thing that they're supposed to go over with them, and usually they ramble them really fast. Complications are very rare, they barely ever happen. They could be bleeding, infection, reaction, possible death, blah blah blah, and then they just keep going on. They usually try to do it pretty quickly. The patient's perspective, a lot of times in those situations, they're very nervous. They don't know what's going on. We had a situation not too long ago with my father-in-law where he was in the hospital. They thought he had a heart attack. He went through imaging, had a cardiac ultrasound, and then they decided that they wanted to do an angiography procedure to see if he had a blockage. And, there was a lot of fear there. He was really nervous. He didn't know what was going on. He was scared. So, even though the procedure itself is relatively easy, that fear is there, that anxiety is there, the worry that something is wrong is there. Patients might have a fear of needles, and a lot of people think, especially when they explain the procedure, you're going to stick a guide wire in my groin and go all the way up to my brain or my heart. I mean, when people think about that's big, that's scary. It's mostly sedated. Like I said, a lot of patients don't remember it. Depends on what the doctor uses. A lot of them, they'll sedate them, but they might not use the conscious sedation, so the patients may remember the whole procedure. If surgery is the only option, then this seems pretty simple, right? It can be exhausting. Have you ever done that where you don't do anything all day and you feel exhausted? Sometimes just having to lay there and have that procedure and the stress of everything, the whole thing can last 6 hours or more. And the patients are going to need to lay flat for most of that. So it can be very exhausting physically and emotionally for those patients. The cost is huge. Okay, so depending on what it is, it's about $300,000 to $50,000. So a line placement for chemotherapy, like a PICC line or a portacath, those are going to start more at like $300. And then a heart angioplasty is going to be about $20,000 to $50,000. So it's just going to depend on the procedure that they're having of what the cost is. But remember, if you're asked, the cost is between $300,000 and $50,000. So this one I do actually have a video for you. I'm going to show you a video on angioplasty stenting. So give me just a second here and I'll pull that up for you.
Your heart gets oxygen and nutrients from blood flowing through your arteries. But fatty deposits called plaque can build up in those vessels, reducing blood flow and keeping your heart from getting everything it needs.
This is the plaque building up here.
One treatment for this condition is coronary angioplasty and stenting. It opens narrowed arteries, allowing blood to flow freely again. When you have angioplasty, you will be awake but drowsy. Your doctor will insert a soft plastic tube into a large artery in your groin. Next, she'll thread a flexible guide wire through the tube, up through your circulatory system, and all the way to your narrowed artery. Then she'll thread a catheter over the wire. The catheter has a balloon on the end, surrounded by an expandable mesh tube or stent. She'll gently guide it to the narrowed part of the artery and inflate the balloon, which will press against the sides of the artery. The inflated balloon will then lock the stent into place, so it will stay open and let blood flow freely again. The catheter will then be removed and your doctor will stitch up the skin where it was inserted.
So I like that little video just to kind of give you an idea of what it would look like. It's a pretty good representation of how they would go through and do that procedure. So contraindications for the exam, anything that would violate the prep. So MPO prep, anything, if there was like a pelvic ultrasound where they had to drink 32 ounces of water, that would violate the MPO prep. So those couldn't be done on the same day. Or anything using contrast that would obscure anything that we're looking at. So upper GI, BE, IVP, or a CT with contrast, those studies would not be allowed on the same day as the angioplasty or angiography. So who performs angiography? It is a group of people. There's multiple people who are actually performing the exam. So there's a radiologist, a rad tech, sometimes an anesthesiologist to sedate the patient. There might be an RN or a surgical tech in there that's going to help assist the doctor with the sterile side of things. So it's just going to depend on the facility that you work at. Each of them are a little bit different. But a radiologist, the person that's actually in interventional radiology, specializes in interventional radiology. There's not just every radiologist doesn't just rotate in there. It's a specialty. And then the radiologic technologist that works in there has already passed the board exam for radiology, and then they train on the job and they take a specialty exam in cardiovascular technology. So their initials would be RTR for Registered Technologist in Radiography, and then CV for cardiovascular. The technologist perspective is with interventional radiology, most of them aren't staffed 24/7, but they'll have on call. So there might be a lot of call when working in interventional radiology. It can be really exciting or intense. These are sometimes very traumatic situations. You think of a patient coming from just having a baby and they're hemorrhaging, or a patient, that has internal bleeding from a traumatic situation, from a car accident or something like that. It can be very intense. It can be high stress. The doctors are trying to save this patient's life. You're trying to help save this patient's life. There can be a lot of stress that comes along with that. It is a surgical atmosphere because, it's a sterile procedure, so a lot of times it's done in the OR like that. You have to deal with people. Sometimes in that intense environment, it's hard to deal with your coworkers or even the patient. It can be, again, a depressing hospital setting, and we're dealing with needles and things like that, so there's always the risk of hepatitis or HIV. I do have a little video here that's going to show you kind of the perspective of an interventional radiographer, and they give you a little insight of what the suites look like too. Alright, here's the video.
Here at Cincinnati Children's, there are many different subspecialties in radiology. Interventional radiology is one of them. Interventional radiology is part of the operating room. However, most of the procedures done in IR are minimally invasive, which in general is safer than open surgery and allows you to recover faster and heal with less pain and scarring. An interventional radiology technologist is different from a diagnostic, ultrasound, or CT technologist because we assist the doctors in the operating room. IR technologists greet the patient when they are coming into the room and stay with you through the whole procedure till the time the procedure is finished. We prepare the sterile equipment in the rooms for the procedures and sometimes are able to assist with performing these procedures. In aiding the doctors, we use sterile technique like scrubbing our hands, putting gowns and gloves on, and cleaning the procedure site of the patients. IR technologists are also a resource in the room during the procedures to get the needed equipment. There are many different procedures that we perform, for example, placing drainage tubes, PICC lines, biopsies, or angiography, which is imaging of vessels in different parts of the body. These are just a few examples. We use many different types of imaging equipment for our procedures. Our main source of X-ray is the C-arm, which we use for almost all the procedures we do. This creates a low-dose pulsed X-ray and allows us to see in real time what we are doing inside the body. Our C-arms also have the capability to do minimal CT scans and make 3D imaging models. IR technologists can also operate the ultrasound machines, which are used to do biopsies or get vein and artery access. This is just a brief description of the day-to-day duties of an interventional technologist. We hope this helps you to understand how we treat our patients in order to get the best results.
So it's kind of neat just to see the perspective of, just a quick little snippet of what they do and how the room's set up and how they kind of function. And I don't know if you noticed at the bottom how she was using those different controls on the table to move the machine and do things there. And, they all had lead aprons on. I didn't know if you noticed that, with radiation monitor badges to help protect the patients. Or not protect the patients, I'm sorry, to help monitor how much radiation you're getting. So career advancements are going to be the same. Most of the time, there isn't necessarily a lead tech or a department manager in interventional radiology. There might be the main manager of diagnostic imaging, but you can also go into sales, application, and education for that. Compensation is going to depend on your experience, where you work, but the compensation is pretty good. I mean, the average salary that I found for salary.com for 2020 was about $36 an hour. Obviously, that's not going to be where they start out, but there is, that, and then your on-call pay. Plus, you're also getting medical benefits. Most on-call pay is going to be very low. I mean, sometimes it's only like $2 an hour for the entire time you're on call. But then if you get called in, you're going to get an increased rate. Each place is different, but you might get overtime, or as soon as you punch in, you get 2 hours of pay, no matter how long you're there, so on and so forth. So really with angiography, there aren't any ethical issues. They're done in hospitals, the patient or the technologist has to be registered, so we really don't have any ethical issues with that. A future of the modality is 3D virtual imaging, MRA, which is not really new, it's here, but there's also some possibilities out there. There's the possibility of doing interventional radiology without radiation. There's this True View technology, which uses like photo rendered 3D ultrasound, so that can actually guide a device using ultrasound and see it in 3D. There's also something called FORS, F-O-R-S, which is fiber optic real shape, and that can visualize wires and catheters in 3D using light instead of X-ray. So those things are very new. I'm not sure if it's something that's going to completely take the place of X-ray or not, but it's the possibility of doing that. So I don't have very many images when it comes to I guess I have more than I thought. So I'll stop right here and then I'll do another video just on the images, but it'll be pretty short.